So near drowning is one of those environmental emergencies that, as a critical care physician, you need to be aware of because you'll see these from time to time. Now, these obviously occur particularly during the summer months when people are out on the lakes, in the rivers, and have their pools ready and they're out playing in the pools. Often they're under the influence of some alcohol or other medications that makes them more predisposed to developing a drowning. Children are also particularly prone to drowning, especially in pools, but because this is not a talk with pediatric ICU, we're not going to talk about children-specific problems in drowning per se. Now, drowning itself, the process of drowning is quite terrifying, and most people would rate that as one of the worst ways to die. Begins with a period of panic, the inability just to suddenly recognizing that you can't swim and that you are literally in over your head causes a significant amount of distress. There's a loss in the normal breathing patterns as the person is trying to guess where the water is and trying to keep the water out of their mouth, as well as breath holding, which only makes matters worse, and then this ongoing struggle just to stay afloat. There's a reflex inspiratory effort eventually actually leads to hypoxemia because they will eventually aspirate either water, which will get into the lungs and cause hypoxia, or when the water hits the larynx, it causes a reflex laryngospasm. Now, in the past, there was an awful lot of distinction made between freshwater and saltwater drowning. And unless you're drowning in the Dead Sea, where the salt content is exceedingly high, this is actually not terribly important. You need to have aspirated about 11 milliliters per kilogram of water in order to have any effect on the total blood volume, whether it's salty or freshwater. And then if you want to have any electrolyte shifts, you need to actually have aspirated 22 milliliters per kilogram of water before you'll see any of those effects. So this is really not an important distinction to make and not something you really worry about because the vast majority of near drownings present with an aspiration of only about 2 to 3 milliliters per kilogram of water. Water aspiration, however, does have significant consequences to the lungs, regardless of whether it's fresh or salty water. The water itself will decrease your compliance by washing out surfactant. It will cause VQ mismatch and interpulmonary shunts. So hypoxemia being a very significant problem with near drowning. And then never mind the fact that you're actually probably inhaling a fairly contaminated water with a number of different bacteria, Pseudomonas species, which can set yourself up for both an aspiration pneumonitis and eventually an aspiration pneumonia. And then unusually you can have, with a large volume aspiration, you can have some temperature shifts as a result of the cold water in the lungs. But that's probably not nearly the most important problem that the patient has at that point in time. So when it comes to the effects of drowning, hypoxia is obviously the biggest problem. But there are a number of other end organ dysfunctions that you need to consider and keep your eyes out for. So first and foremost, when you take in a large volume of water and then cough it out, you wash out surfactant, and this can lead to acute lung injury or even ARDS. Hypoxic brain injury is a significant problem, and you should treat this as you would treat anybody who has suffered a serious anoxic hypoxic brain injury. They can develop secondary cerebral edema, which then worsens their underlying brain injury. These patients may have myocardial injury and are prone to having arrhythmias, or in fact may have had an arrhythmia as the cause of their drowning. And so you need to watch out for the possibility of arrhythmias, either caused by the hypoxemia or as the cause of the drowning itself. Hyperthermia, or rather hypothermia, can be a significant issue because most of these patients present not only with the drowning, but also with the environmental exposure of hypothermia as well. And so treating the hypothermia is also important, although, again, in the context of an acute brain injury, you don't want to necessarily bring their temperature back up to normal, but want to at least prevent them from getting their temperature too low. As I've said before, if you have a patient who's drowned in the Dead Sea, then you might have to worry more about the consequences of electrolyte shifts. And if somebody has drowned in the Dead Sea, you need to watch out for hypernatremia as well as hypermagnesemia, as these are the predominant salts in that water. But for the vast majority of the time, you don't really have to worry about electrolyte shifts or volume shifts as a result of the aspiration itself. So the management of patients who have suffered near drowning is pretty straightforward, but there are a few things that you need to really watch out for. Now obviously, first things first, A, B's, and C's. Make sure their airway is secured, make sure that they're breathing, and make sure that they have adequate circulation. And beyond securing their airway, oftentimes you're now dealing with the consequences of the drowning and the hypoxemia, or you're dealing with the thing that precipitated the drowning and the things you got to watch out for. And it's important that you should recall or should consider a near drowning as a trauma, and so you should do a proper trauma evaluation from head to toe. Now there is no role for putting somebody in C-spine precautions directly unless there's an actual history. And this is primarily for people who have suffered a drowning as a result of a diving incident. Then you need to worry about them having a C-spine injury. But for the vast majority of people who swim out into the water, get in over their heads and drown, they haven't suffered a C-spine injury. And this placing them in precautions really is not necessary at all. You need to also protect them from hypothermia, not letting them get too cold, but also not letting them warm up too much because you want to provide some level of cerebral protection. And then look for other antecedent causes that may have contributed to the drowning, such as the arrhythmias, as I've mentioned before, looking specifically for prolonged QTs or evidence of any other malignant arrhythmias. And then also looking for and treating any possible seizures. Because remember, seizures in the water can cause a significant drowning. You need to protect them from, you need to provide the usual neuroprotection for hypoxic anoxic brain injury. Watch closely for the development of secondary brain injury from cerebral edema. And then finally, follow them closely over the course of the next several days to look for evidence of ongoing infections from the aspiration event and also the development of acute lung injury and ARDS. So the outcome, as you can imagine, for near drownings is not that good. Unfortunately, there's often a poor prognosis associated with the drowning and the prolonged hypoxemia. A number of factors that are associated with a poor prognosis include a submersion that's greater than 5 minutes. And this is probably the most important factor that you need to get from the history to give you a sense of how this patient's going to do. As well as the time to basic life support greater than 10 minutes, they're at a higher risk for a poor outcome. And then any time where the resuscitation has been going on for more than 25 minutes, that are at a higher risk for a poor neurological recovery. Age is actually protective if you're under the age of 14. However, since we're in adult ICU, and most of these patients we're going to see are adults, and their outcomes are not going to be as good. There's much more resilience in children than there is in adults. If their initial presentating GCS is less than 5 after initial resuscitations, you need to be concerned that this is a significant anoxic brain injury that they've suffered, as well as any need for CPR while in the emergency department or a persistent apnea after the arrest are all things that you should be very concerned of. And then finally, the initial arterial blood gas, not venous, arterial blood gas, pH of less than 7.1 suggests that the hypoxia has been prolonged and the downtime has been long enough that the outcome, unfortunately, will unlikely be that good. And so consider these factors when you're speaking to the family to give them a sense of how this is going to go for them. So that's all there is for today. If you have any questions or comments, please feel free to